Hello, everyone. Thank you so much for tuning in today and listening to this talk. So like Dr. Moore mentioned, I'm going to be talking about antidepressants and why we use them in pain specifically. So a little bit about me, my background. So I actually grew up in England across the pond, was born there. I did medical school there in the UK. It was 6 years. And then I moved over to the US. I was in Miami. I did my anesthesiology residency. I finished the residency last year, and then I started to do my pain fellowship here at Stanford in July of last year. So I'm very happy to be here, and I'm very passionate about this subject. So I hope you guys get some useful information out of this. So we can start with talking about how pain is defined, and this is pretty important to why antidepressants are kind of connected to helping us manage pain. So the International Association for the Study of Pain, the IASP, in 2020 updated their kind of definition of pain to being an unpleasant sensory and emotional experience associated with or resembling that associated with actual or potential tissue damage. And I underline sensory and emotional experience because these are clearly very important parts of pain, and they have maintained both these things in their recent update for the definition of pain. Specifically, the IASP also comments on the definition of chronic pain, or defines chronic pain with being pain in one or more anatomic regions, that means areas in the body, that persists or recurs for longer than 3 months and is associated with significant emotional distress or significant functional disability. So that means interference with activities of daily life, participation in social roles. So this, I kind of, again, put these things in bold: the significant emotional distress, significant functional disability. And I'm sure a lot of you who are in pain understand that this can impact your life in many ways. So let's talk a little bit about the basics of pain and how it is transmitted. So we have a central nervous system, and on the left here, I've noted the brain and the spinal cord are part of the central nervous system. And then all across our body, not just in the skin, but all of the soft tissues, bones, and internal organs, we have peripheral nerves. There are 2 different types of peripheral nerves, and I think the one that's important to us here is a sensory nerve, which is what will transmit pain as a sensation. Importantly, the information from all of these nerves and the peripheries enter the spinal cord and travel up to the brain for processing. So getting a kind of closer look at what is happening specifically with pain in these sensory nerves. So how is pain transmitted? First, we have transduction, and this means when there is a painful physical or chemical stimulus that is transformed into a signal that can be carried along the nerve to the cord and then to the brain. The transmission, like I mentioned, is when that signal is then carried along that nerve to the spinal cord. And it's important here because there is, like the slide mentions, modulation in the spinal cord. And what does that mean? So this means that the signal is either left unchanged, it is either intensified or dampened and then sent to the brain. So there's some control in your spinal cord and some potential changes that can occur in the spinal cord before it gets to the brain. And then we go to perception when we get to the brain. Specifically, the area that processes pain in our brain is called the anterior cingulate cortex. And we're going to move on to the next slide here, which will show us a little bit more about what's going on in the brain. So the signals that are being transmitted from the spinal cord, like I mentioned, first travel through a structure in the brain you can see in green on the diagram called the thalamus. This is like a big sensory hub. You can imagine it's like a large airport where a lot of different people are coming in and out. And instead of people, we're talking more in the brain of the nerves. So not only do the pain signals travel through this structure, but actually all other kinds of sensory input also travels through the structure. So it can be vibration, light touch, other sensory experiences around you can be traveling through the structure. So we have an area where pain is traveling with not just other nerves that carry pain, a lot of other different types of sensory nerves. After passing through this structure called the thalamus, the signal is then transferred to that area that I mentioned that processes pain specifically, called the anterior cingulate cortex. It's kind of hard to see. It's not labeled here, but it's just above where it says cortex, and it's kind of here. Now, the important thing here is realizing that the area that processes pain perception is neighboring several areas which perceive things like mood. So we have in the diagram, says the limbic system. And so this is where some of our mood is processed. And then additionally, emotions processed in the hypothalamus, which is the little blue structure down here labeled, and also the amygdala, which is another structure for emotion. So these areas, again, are not only neighboring structures, but are highly connected between the nerves. And so signals are almost always transmitted, often in like a circuit type fashion, crossing over these areas. And so there, again, there's a chance of information to be modulated or changed. Depending on your mood, your emotion, pain, all of these things can impact each other in kind of a crossover style. And here I've just highlighted that. So this is a kind of the basis of our understanding of why pain, sensation or sensory experiences that are not painful, mood and emotions are all very, very closely linked. So then we talk about antidepressants and pain and how we're kind of approaching this topic. So there have been multiple studies that have shown patients with chronic pain have an increased incidence of psychological factors or psychological conditions. The two most common that are described in the literature are depression and anxiety. And I think that a lot of literature also specifically describes depression predominantly. So some information and evidence regarding depression and pain. So there's a literature review that I wanted to discuss from 2003. And this looked at studies done from quite a long time ago. So from 1966 through July of 2002, a lot of studies were involved. So 42 studies, including well over 1,000 patients, focusing on how many patients with pain also had symptoms of depression. So it highlighted that pain and depression are linked in such a way that having pain negatively affects recognition and treatment of depression, but also when the pain is moderate to severe, it actually impairs your function, and then the depression actually also becomes harder to treat. So this overall kind of leads to a lower quality of life and functioning. And similarly, when there's pain and depression are paired, the pain complaints can be higher and associated with a greater functional impairment. So not only does it work one way, it does also work equally the other way. So pain and depression are very much connected. They also highlighted that depression and pain share biological pathways that are similar. So the pathways, like we discussed, in the central nervous system, the brain and the spinal cord, and also the neurotransmitters. Now, what is a neurotransmitter? These are the chemical signals that the nerves release to transmit messages along. And so not only do they share common pathways, but share certain chemicals that are also very similar. And this shared kind of network has implications for the treatment of both of these conditions. So this is really important. And then the second sentence on the slide talks about another more recent review done in 2018, looking at 28 articles and studies, which again showed that patients with pain and depression experience reduced mental and social functioning as opposed to patients with only depression or only pain. So the outcomes in terms of physical, mental, and social functioning were reduced when both were present. And again, they highlighted that the biochemicals, like we talked about, and the pathways involved in pain and depression are shared. So these shared biochemicals they talked about are two things, one called norepinephrine and one called serotonin. And these are the chemicals which the nerves in these circuits of pain and depression are releasing to transmit and send signals along. And I just wanted to highlight that it's not only these reviews that have looked at this, there have been several other studies that also show this link. So studies specifically on using antidepressants in pain. Since we now know that there is a shared kind of biological pathways, shared biochemical link, let's focus now on how we have developed ways to use this to help treat our patients. So there are a lot of different antidepressants, a lot of different classes of antidepressants. And we're going to focus on some of them that act on these biochemicals that we discussed. So norepinephrine and serotonin. And so the two main classes of antidepressants are the TCAs and SNRIs. We'll talk more about these in a moment. So let's start with the TCA class. There was a large review done in 2007 looking at 61 randomized control trials. Now that means that the patients did not know which specific medications they were receiving, but they were asked to comment on whether their pain was better after receiving that medicine. So it showed that for every 3 patients that were treated with a TCA, that at least one of those patients would get moderate pain relief. So 1 in 3 patients was their kind of number and the results of what they found. Similarly, they found that another medication called venlafaxine, which is part of the other group that I was talking about, the SNRI class, would also give at least moderate pain relief 1 in every 3 patients. So that was interesting. More recently, we've had studies looking at other SNRI medications and specifically one called duloxetine, which has been particularly effective as a treatment options for pain in diabetic neuropathy, fibromyalgia, and also osteoarthritis. And it's actually since then been FDA approved for these conditions. So this has obviously led to an increase in us being able to use it more readily because the evidence has been so good around this medication. So a little bit more about the types of antidepressants that I just talked about. So like I mentioned, there's the TCA or the tricyclic antidepressant class, or the SNRI, which is the serotonin and norepinephrine reuptake inhibitors. They're very long names, but we're going to talk a little bit more about how they work. So let's start with the TCA groups. And some of you may have come across some of them. Usually end with triptyline, nortriptyline, amitriptyline are some of the common ones. And more recently, we're now starting to also use desipramine for pain. So how does this work? So these medications work to increase the amount of those two biochemicals that we're talking about. So the norepinephrine and the serotonin. They work to increase how much of these chemicals are available in the brain and in the spinal cord. And if you remember, these chemicals work for pain and depression both. And so that's why we have a couple of different locations of where they're kind of highest in their concentration. They work, as shown in the diagram, in the spinal cord. And in the spinal cord, they work to increase the levels of these chemicals to block the pain signals that are then sent up to the brain. And in the brain, these increased levels will help to restore and normalize function implicated in mood. So we have two areas, and both with implications for mood and pain. And so what about the side effects? Because a lot of the times we can convince you to take medications, but it's really important for you to be able to make an informed decision to know what the side effects and the risks of these medications are. So apart from the two biochemicals that we talked about in mood and pain, the TCAs also act on some of the other receptors in the body that can cause some of these side effects. So commonly patients will report dry mouth and dry eyes. Sometimes it's too bothersome and patients aren't able to continue because of the dry mouth. The other common one is drowsiness and a sort of brain fog feeling, or feeling a little bit sleepy. That can happen. And so sometimes we advise patients to take these medications when they start at nighttime. The other important thing is that we do not typically prescribe these medications with patients with history of heart problems, where they're prone specifically to having irregular heart rhythms, as it can cause an increase in your heart rate. But this is only really a problem if you already have a heart condition. In patients who are healthy and have normal hearts, a slight increase in your heart rate will not really change anything. Other things that are less common but could also be experienced are things like constipation and urinary retention, but these are typically occurring in patients who've already had pre-existing, for example, constipation, or if you're a man, if you've had prostate problems and you've already had problems with urination, this could potentially affect that. What about the other class, the SNRIs? So like I mentioned, duloxetine is something that we're using a lot because it's FDA approved, has good evidence for a lot of different painful conditions. Venlafaxine we don't use as much, but it's also part of that group of medications. A lot of the time psychiatrists will use it because it's very good for anxiety. And duloxetine also has some good, what we call anxiolytic properties. So it's also good for patients with, I would say, I guess, mild to moderate anxiety. So how did this class of medication work? So again, this one has a little bit more of a description. It's in its name itself. So it's a serotonin and norepinephrine reuptake inhibitor. So again, we come back to those two biochemicals that are highly involved in pain and mood. And again, both of these chemicals are increased when you take this medication because it basically prevents the nerves taking these up and reducing the available levels. Like I mentioned on the last slide, duloxetine is FDA approved for both pain and psychological conditions, and several pain conditions, like I mentioned, the osteoarthritis, fibromyalgia, diabetic neuropathy. So we tend to use it favorably over venlafaxine, which is only approved for psychological conditions in terms of FDA approval currently. So what about the side effects of SNRIs? It's important to mention that you'll see a lot of similar side effects here, things like dry mouth, drowsiness. Those are the kind of the general ones. I think the most important one here that is different and important to mention is that the nausea and abdominal pain, it still occurs only in a small subset of patients, and it's not that it causes damage to the stomach in any way. It's just one of the symptoms that occur initially when you first started taking this medication. And then it tends to resolve after a few days if you're able to tolerate that period of time. And so what about pain psychology? I'm sure a lot of you have experienced that we tend to get into a cycle with pain and mood. So it's really nicely demonstrated here in this diagram that with pain, you start to do less, you socialize less, you generally enjoy things less, you're upset, you're stressed, it's frustrating. And this can lead to low mood, depression, frustration, anger. Some people are tearful, and so a lot of different types of emotions. And then this affects your overall ability to be able to then manage the pain that started this in the beginning. And then you end up feeling worse. And so you're kind of in this constant cycle, leading to an overall reduced quality of life. So how can pain psychology help? I'm not a pain psychologist, but I do really value what all our pain psychologists do here. So I'm going to touch briefly on what and how this can help. So I think it's really important to notice that sometimes in medicine, we tend to think that, medications, procedures, all these things can be applied to every patient and it will always help. But I think what's really important to realize is that we're all different in the way that we perceive pain, but also depending on the context of your pain and what the pain means to you, the impact it has on your life. It may not be the same in everybody. And that's really important to realize. We know that pain signals going to our brain travel through a circuit where there is a lot of input along the way that can change the pain signal that's traveling. Particularly, we discussed in the brain where there's cognition, emotion, and mood so closely linked. The pain signal can change along the way, and it's influenced by all of these things. So what can we do knowing all of this? There is a review done in 2017 showing that a multidisciplinary and biopsychosocial approach to pain management helps patients to actually individually take control of their pain, which is unique to their situation. And so, what is this biopsychosocial approach that is part of this multidisciplinary care plan? Well, this can encompass a lot of different techniques, which our pain psychologists are experts in. I wanted to touch briefly on something called CBT, which has been studied extensively, and some of you may have come across or found helpful. So a little bit about this. A review done in 2015, looking at 35 studies, showed that CBT, or what we call cognitive behavioral therapy, reduced pain in at least 43% of patients. There are several other reviews and studies out there which actually quote more than 50%. Now, if you think about it, if medications reduce pain by 50 or 60%, like we discussed, and cognitive behavioral therapy also does it by this amount, together we're getting close or wanting to get close to trying to get you to 100% pain relief. Now, it's not to say that this combined technique can cure your pain away to 0%, but it gives us a scenario where we can try to reduce your pain and get close to that and get you comfortable, at least by any stretch of imagination, get your pain to at least 50% better. That's what we hope. So cognitive behavioral therapy is focused on working to change unhelpful ways of thinking and unhelpful behaviors that we can get into with low mood and pain, like I discussed with that vicious cycle that we can get into sometimes. If we can somehow change and regulate our thinking and behaviors, we can in turn cope better with pain, but also with our mood. We can, in the end, just improve our quality of life and also day-to-day functioning. And this is really important in something like chronic pain, where the problem has been long-standing and sometimes there isn't something specific that can be fixed with surgery necessarily, or something invasive like that. So it's something that we have to learn to manage. And I think that this is an excellent way that is non-invasive, doesn't have side effects like medications can. So it's definitely worth a try, and we recommend it for a significant portion of our patients. So what psychology resources are there? So our Stanford pain psychology team has a very robust, excellent service. And like I said, I refer a lot of the patients I see every day to them. There are also community psychologists that specialize in a variety of different things, which we can then refer our patients onto as well. And then we have to think about helping ourselves. We could learn these techniques from our psychology experts and then continue to practice them at home and do our due diligence on a regular basis. And often, like I mentioned, in chronic pain or chronic conditions, you need to kind of have some maintenance therapy, and that will really help in the long term. And then we have technological advances, and there are a lot of helpful apps out there. I think we usually recommend our patients to try Curable, which is a chronic pain relief app. I have it on my phone. I do some of the exercises on there. It's actually very good. They also have a lot of audio recordings that you can listen to, similar to kind of the talk that I'm doing today, but in smaller chunks, so it's easier to digest. So those are really helpful just to understand the science side of things in a very useful way that we can apply to ourselves. And then, like I mentioned, it has different exercises and techniques that you can just practice at home on a daily basis for that maintenance therapy, for when you're, for example, not seeing your psychologist, or you can still maintain that therapy at home. So that I thought was pretty neat. So other than medications, what options do I have? So just to summarize, we like to attack managing pain in a lot of different ways. This talk is not just about antidepressants and pain. It's about overall getting you in a better place with pain and mood. So some of the things that come to mind, other than medicines and psychology that we discussed, things like exercising, moving, doing some physical therapy. This doesn't mean that you have to do vigorous or strenuous exercise every day, but it does mean that you have to do what you feel comfortable with on a regular basis. And this is important because a lot of studies have shown, and physiologically, that means scientifically, that a lot of movement and exercise actually increases the amount of these neurotransmitters or biochemicals that we were talking about. The other thing would be sleep hygiene. And so what does that mean? Getting into a good routine with sleep and in a timely fashion, trying to optimize what works for you in terms of sleep, timing your food around, not having it too close to sleep time, making sure that you you're able to sleep through the night, and making sure that you're not sleeping through the day so that you can't sleep at night. A lot of different things go into sleep hygiene. I'm not an expert, but this is something that's really important. And a lot of our patients highlight that when they don't have good sleep, that their pain is worse. So sometimes we do refer our patients on to the sleep clinic if they have significant sleep issues. And this is not only important, and what's the link with pain is that actually sleep is very much involved in regulating our central nervous system function. And it's very closely linked with how that is regulated. So it's very important because our nerves that transmit pain are part of that nervous system. And lastly, things like social engagement. Sometimes we have to do things a little bit outside our comfort zone and continue to see friends, even though we're not feeling so great. And so this is really important to keep up, because you never know what going out of the house or seeing a friend, in what way they can help you. And I think this is something that goes under recognized, and I think it's really important. So in summary, like I mentioned, a lot of our patients get the most success approaching pain and reducing pain using not just one of these techniques, but all of these things. Some patients prefer to start with one or the other, and then they move on to doing them kind of in a sequential order. In any case, we've noticed that usually a combination of all these approaches works the best. So not just taking antidepressant, pain medications, not just working with pain psychology, not just working to exercise and get good sleep, but doing all of these things together. So these are some of my references from some of the studies that I discussed today. If anybody has any questions, that would be the end of my talk, and thank you for listening.